Okay, now it's recording. So I'm gonna show you the last topic. So here we have an can you see my screen? Okay, so this is the last thing that we need to check: the myasthenic syndromes and the muscular dystrophies. And what you need to know from these two things, and as I told you the other day, for the exam, what you need to do is to actually answer these objectives, right? So if you know the answer for every of the things from these objectives, it's going to be easy. So, for example, here we need to check how antibodies generate damage to the neuromuscular junction for the myasthenic syndromes, explain the mechanism of action of the management of myasthenia gravis or Eaton-Lambert, and explain how proteins translation mutations such as dystrophin generates these syndromes, and how to treat them actually, basically. So that's what we need to answer, and that's what we're going to try to answer now. So we're going to start with myasthenic syndromes. Okay, so and here what I have is just a reminder of what we saw last time. It's just how the muscle and how the so sorry. What I wanted to say is that if you do kind of a table of all of these the specific parts of these syndromes that we're going to see, for you it's going to be easy to remember what is the pathophysiology, why they are different, and in most of the cases, for example, the treatment is the same. The prognosis is the same. So we just need to check the small things that they are different, and that you are going to understand it. So you differentiate them with a table, and then we understand the basis of these two things: the dystrophies and these myasthenic syndromes. So what I wanted to highlight here, where we have, so you can see the presentation, right? Yeah. Okay.
Yes.
Thank you. So here we have, for example, this is where we saw last week how the acetylcholine arrives to this is the axon of the neuron. The neuron release the acetylcholine, and then the acetylcholine binds to the receptor in the muscle, and then the muscle generates an action potential and contracts. Okay, that's basically what we need to understand. And then we're going to see these syndromes and this pathology. So basically, the myasthenic syndromes are characterized by abnormal fatigability of the muscle. Weakness can affect some muscles or all the body at once. And there is a problem in the how the impulse, the nerve action potential is affected while releasing or while attaching the neurotransmitter, and then that's what we're gonna check. And if we talk about the myasthenic syndromes, we're gonna talk about autoimmune disorders. Okay, so myasthenic syndromes, autoimmune disorders. Good, there, good, perfect. I'm just following what Pame says. If Pame nods, then it's I continue. Okay, we're going to start with the first one. Okay, so if this imaginary table that you should be writing and that you should be kind of doing it, we have the first one, that is myasthenia gravis. Okay, so we have, this is the normal neuromuscular junction. We have the acetylcholine that is releasing. It binds to the nicotinic receptors in the muscle and then generates a contraction. So in myasthenia gravis, we have that the antibodies attack the acetylcholine receptors or the nicotine receptors, the muscle-specific kinase, or related proteins to the end plate. Who can, and also, I mean, these antibodies are present in the serum, in the blood, in elevated concentrations, and that's how can be diagnosed, right? What would be the effect of having antibodies for these receptors in the muscle? What will happen to the muscle? What will happen to the contraction? Who can guess? Who can take a guess? I mean, this, I don't expect you to know. I just expect, like we go back to what we were saying last week. Everything is very logic, right? So we have antibodies here. They join to the nicotinic receptors.
The muscle can't contract.
The muscle cannot contract. Perfect. Why?
Because the acetylcholine receptors are the one who signal for the contraction of the muscle. So if there's a lack of those receptors because the immune system is destroying them, then it can't receive the signal to contract.
That's perfect. One thing, it's not actually destroying them at this point, but this is exactly so. What the antibodies do, they just block. I mean, they can also attack the receptors, but one of the main things is that they block the receptor, so the acetylcholine cannot bind. Okay, so for example, what would you do to treat this disease?
Give something that would like block those antibodies.
Okay, that's one. Okay.
Or maybe give like synthetic acetylcholine.
Okay, that's good. Why? That's a good thinking. Why do you want to do synthetic acetylcholine?
Because if the antibodies are like attacking that specific type of acetylcholine, maybe you could like give acetylcholine so that it would like regulate each other. Okay,
I mean, yes, that's basically the treatment is not to give more acetylcholine. I mean, that's a good guess, Vale. So the thing is, here what we need to do is to make the acetylcholine to last longer in the synaptic cleft. So, I mean, it's difficult to give more acetylcholine because then you will have contractions all over the place. So you just need a contraction when you need it, right? So in this case, what we will try to give is acetylcholine inhibitor, enzyme inhibitors, just to avoid the degradation of the acetylcholine, to maintain more the acetylcholine there, so then we can actually they can bind to the receptor and make the movement. So this is basically what is myasthenia gravis. So how we can actually detect it is when we have this electromyogram of this patient. So normally when you can innervate a cell, right? So you can innervate a cell and then you can make a contraction, right? So I don't know if you know, but why do we know? Did we know that or we are electricity? Is because many years ago, someone called Galvani realized that if you put some electricity in a leg frog, detached from the frog, of course, the leg can still contract. And then that's how all the electrophysiology and all the electrical things they start to be like investigated and everything. So the basic of this is they realize that actually the body can conduct electricity, and then there was a point that there was madness, and then there were the scientists or the doctors were going with electricity. When someone was dying in the street, they were just coming with more electricity and just put it there, and then people was getting the heart to pump again, and then they were surviving some of them, and then there were other people were just getting totally and completely burned by the electrical shock that in the past were giving. So this is the whole thing, right? So when we put an electrical stimuli, we will have a reaction of the muscle. The problem with the myasthenia gravis and what makes it different is that here, this should maintain the same amplitude. So it means that when you give an impulse, then you give a second impulse of the same magnitude, you should have the same response in the muscle. The problem here is that the muscle is decreasing and decreasing and decreasing every time. Okay, so this is how we can differentiate the myasthenia gravis. So every time here, the electrical activity is reducing. The same curve shown. Where would you have? Yeah, the muscle potential diminishes from one stimulus to the next, and it's getting slower and slower. Like normally, it shouldn't be more than 50% decrement every time that we're trying to stimulate a muscle. So this is important, and just is because we cannot bind the acetylcholine to the receptors to the nicotine receptors. This is a disorder that affects 1 to 4 people in 100,000 people per year. There are a lot of people that suffer about this. For some reason, women are more commonly affected than men, and the onset of the disease is usually in the 2nd through 4th decade of the life of the women, but in the older in men. This is important because 3/4 of all patients with myasthenia gravis have hyperplasia in the thymus, and 50% they could actually develop a thymoma. What is that? ¿Qué es el timo? What is the thymus? Where it is? What it does produce?
Well, there's where the T lymphocytes mature, right?
Yep. So this is where the T cells are produced. It's a gland. Where is located?
In the chest?
Yes. Yeah. Just like in front of the lungs, and the heart. Okay. So why do you think that these patients have these things? They produce this? Or like a thymoma, cancer?
Maybe because of the overactivation of the immune system.
Perfect. I mean, that's it. This is logical, right? We have that for some reason. You start attacking some antibodies, your own antibodies, like how many muscles we have, how many receptors for these muscarinic receptors we have. It's crazy the amount, right? So then if we have to fight with all of this from all our body, of course, this is going to be an overproduction, and it will affect the gland that actually produce the T cells. So this makes sense, right? Somehow. So here, normally it's abnormal fatigability of the muscle. The muscles get tired, for some reason, we have the extraocular muscles and the muscle of mastication and deglutition most obviously affected. I think maybe because we use them more, and the early manifestations are including diplopia, ptosis, dysphagia with frequent aspiration, and difficulty to chew food. So repeated activation of an affected muscle groups leads to rapidly worsening weakness. And this is because the muscles, this with the repetition is what happening. You are losing the sensitivity or the sensitivity to the receptor. And it might be because of the internalization of the receptors, for example. So here we have it. There is the clinical features, progressive weakness, as I was saying, and then to find it. So we have the EMG that I was telling you, and then elevated serum of antibodies against the receptors. Now, what we talked before to treat it is the same, right? So in this case, we cholinesterase inhibitors can improve the disease manifestation. So then you have more acetylcholine to bind to the receptors. And then are also some immunotherapies for acute exacerbation of myasthenia gravis with impeding respiratory failure, like immunoglobulins. And in some of the patients, we need to check the thymectomy, since this is leading to cancer. So this is the first one. So we have that the antibodies bind to the nicotinic receptor, and now we have the Lambert-Eaton syndrome. Okay. So please read this part, and someone explain me what is the difference with this. So there is also antibodies, but what is happening and what is actually the effect of that?
That is blocking I think the voltage calcium channels, or what?
The antibody, yes, it's attacking and blocking the calcium, the voltage sensitive calcium channels. So what's going to be the effect, Ana Sofia?
I guess there's gonna be a less efflux of calcium, so there's going to be less neurotransmitter release.
Okay.
That there's gonna be
yeah. Tell me.
there's gonna be less influx of calcium, so there's gonna be less release of neurotransmitter.
Yes, and then if you try to move it again, I mean, if you want, what would you think will happen if you give another stimuli to release the more neurotransmitter?
There could be hyperactivation of some parts.
Yeah. So actually, that's true. So since, for example, it is difficult for these patients to have calcium going inside of the presynapses here. So the next time that you need to improve it, you need to move it like repetitively, and you have a next stimuli, then you will have already calcium inside. So the next event will be easier to reach. So here we don't have the problem in the postsynapses in the acetylcholine receptors, but in something that is needed to release the neurotransmitter. So this is very important. So we have the myasthenia gravis. It was postsynaptic. It was binding to the acetylcholine receptors, and now we have the Lambert-Eaton syndrome that the antibodies are binding to the voltage-sensitive calcium channels in the presynapses of the acetylcholine neurons. So this patient is basically these patients are the result of small cell carcinoma of the lung, since they have some similar voltage sensitive calcium channels on the cell membranes of the carcinoma. So the cells or immune response actually is recognizing these calcium channels. So then it start to produce antibodies for them. Questions until here? No? Okay, we have two, right? So we have the myasthenia gravis, postsynaptic receptors, and then we have the Lambert-Eaton syndrome. So the clinical features of these ones is just the muscle weakness, fatigability as well, but in this case it's more lower limbs. You remember? Sorry. In the myasthenia gravis, we were talking about the muscles in the face, and in here the extraocular muscles are sometimes mildly affected. Also, this is the difference. We're going to talk about lower limbs in the Eaton Lambert-Eaton syndrome, and this is something that makes it different. Muscular strength transiently increase at first with exercise because of this. So it's a bit difficult to see, but here we have how the like when you try to move, like you try to stimulate the muscle, you are winning activation one time of the other because you have more calcium inside of the cell. So it's easier to release the neurotransmitter in the next event. So this is something that does. So here is the difference here with the myasthenia gravis. Okay. So then we have the treatment. So sometimes here, if we can put immunoglobulins and plasmapheresis to corticosteroids, and in this case, the cholinesterase inhibitors are not very effective. But there still are a bit of like they can actually have some effect, since what you need is to make the movement, and then in the next release you will have, if you have these cholinesterase inhibitors, you will have some more acetylcholine in the synaptic cleft for making the movement. And those are the two immune syndromes that I want to talk with this, basically to understand what is the difference between them and the synaptic cleft. And yes, questions? Easy, right? Yeah, Pamela says that is easy, so it is. Perfect. So cool. Now we're going to muscular dystrophies. We have several muscular dystrophies that we need to touch upon, but this is very, very, very simple. I mean, I don't want you to memorize everything. It is it's actually kind of simple if we find something. And when we're talking about muscular dystrophies, we're talking mainly about genetically determined muscular dystrophies, and that by any reason it will atrophy the muscle, right? So that's what we need to understand. You have a symmetric muscle weakness, mainly proximal, and slowly worsens over the years. So it's important for you to know that I don't know why, but it's actually affecting the proximal muscles. There is no pain or sensory deficit. Sometimes the atrophy is actually masked by intramuscular deposition of fat tissue, and the reflexes are diminished or absent. So we're gonna explain why we can have this change in the muscle due to genetically or gene defects. Hereditary muscular dystrophies of the X chromosomal inheritance. What it does mean? What would you think if I'm telling about X chromosomal gene defects?
That they are more common in men.
Yep, exactly. So that's something very important. Okay, it's genetic defect in chromosome XP 21.2, and there are therefore almost exclusive seen in boys whose mothers are healthy carriers. So something that is very sad about these genetic defects is that there's not a good prognosis for this. To understand the muscular dystrophies, we need to understand about the most important protein for this, that is dystrophin. Okay, this is dystrophin. And basically what the dystrophin does is like work as an anchor between the cytoskeleton of the cell and the membrane of the cell. So if you remember what we saw last week, how the contraction is happening. So if you actually we think very deep into how the muscles can lift so much weight, like how it's just some tissue can actually really lift 20 kilos, 40 kilos and not breaking, is because of this protein, right? These proteins are actually generating that there is a good anchor between the cytoskeleton of the muscle and the membrane for when the contraction is needed. So they are very important for that. It's a structural protein of the muscle fiber that is also expressed in the brain. So which means that if in some of these patients, we will have also cognitive problems. So we're going to see it now. So this dystrophin complex is called dystrophin glycoprotein complex, which is found in the cell membrane of muscles and is involved in maintaining the structural integrity of the cell during membrane muscle construction. Actually, I don't know. I find it very impressive how our body works in general, but these kind of small things that actually maintain the integrity of what we need to move, for example. And of course, when you messed up with this protein, then you have fatal consequences. So this is what I was telling. This helps to stabilize the cell membrane and distribute the forces generated during muscle construction, thereby protecting muscle cells for damage and rupture. So this is why they're so important. So then we're going to see the different syndromes, and here or dystrophies. Here this is where I want you to do the table. I have that table for you. Okay, I have it at the end, but it's easier if you just write the things that I'm gonna tell, because the table is a bit maybe too, I don't know, too massive in many cases. So we have Duchenne muscular dystrophy. Okay, this Duchenne muscular dystrophy. It's mainly affecting young boys, like in the 5 to 10 years old, in the preschool years. The earliest abnormalities are difficult climbing stairs, lumbar hyperlordosis. So this kid is using his hands to actually to stand up, para pararse. Over the few years, the weakness progresses in the proximal muscles, and it affects the muscles that are also in charge of respiration. So this is very important. Okay, I want you to have this very very well understood. So, for example, this is.
Sorry, quick question.
Yeah.
What do you think? Like we should put in the table. Like, do you? I don't know, like epidemiology. That.
Yeah. So basically, I mean, I will show you the table. Okay. So here are the table. So here, for example, you don't need to know which is the chromosomal, in which part of the chromosome you have the defect, right? This also I don't think important, but this is important to know if the dystrophin is there or not, the age of onset. Okay, so that's also important. The clinical features, I mean, and it's good to know, kind of. And then the prognosis is also not very important. But for example, here I'm gonna show you how do they look in all of them. The muscle. Okay, this is a staining of the muscle, and then if you say, okay, the Duchenne's, it's like in the early stage of the boys, they have difficulties to climb stairs, and affects the proximal muscles. These, for example, there is some definitions that these are phonic walk, that they cannot walk very well due to that affects, for example, the hip abductor. So then it's difficult for them to have a good balance. Some of these boys are mentally retarded, and we can find this absence of dystrophin with a biopsy of the muscle. So, for example, this here, you can see that here these are the muscles, the sarcomas of the muscle, and then here this is a normal patient. This is how it should look like. And then, for example, in here, this brown thing here is the dystrophin. Can you see dystrophin in this one? So this, for example, totally absence of this dystrophin. This is for okay, if I can see. Yeah, this, I mean, a patient, and this is a women patient. So, for example, you can see here you have some dystrophin, but then there's some of them that they don't have. So I would say this would be a milder effect. So of the Duchenne muscular dystrophy. So this is the first one. Then we have Becker muscular dystrophy, and if we go back, the treatment is quite complicated, okay, because it's genetically affected. So we're going to see the treatment at the end, and the treatment is for all of them. I mean, again, the prognosis is not good for them. So we have Becker muscular dystrophy. And here what is important that you put on your table is that dystrophin is not wholly absent, but is reduced, it's expressed in reduced amounts, kind of like this one for the female, right? These are affected in the first or second decade, and the progression is slower than Duchenne. And the patients lose the ability to walk later until 40s and 50s, for example, they can die. So this is what we see. It's present but reduced. So this is what I want you to take from this disease. Then we have the facioscapulohumeral type. Yeah. What do I have here? Yes. Yeah. So here, again, autosomal dominant, this part of the chromosome 4, this is not actually important for you to remember. And I think we also, I mean, there are two things. I'm showing them in the cases of where these dystrophies are more common, like we have the most common is Duchenne, then we have Becker, then we have this one, and that also they are the most aggressive, for example. This one is less aggressive than the other two. Then we have the name of the disease comes from the typical initial manifestation of weakness, muscle phase. They begin in the second or third decade of life. Closing, whistling, elevation of the arms. Sensorineural and deafness is often present, and the life expectancy is normal. So in comparison with the other two, so we have the Duchenne's, the patients die quite young. Then we have the Becker that goes a bit later in life, 40, 50 years, and these they can live like normal. And then we have the last one. Okay, we have the myotonic dystrophy of Hirschman-Steiner type. And this is the most common myopathy of adulthood. There's also in this chromosome that will encode to this protein kinase. Here is markedly reduced the expectancy of life, but doesn't say how much. So just I would say maybe in this one it should have been before. So we have which is the most which generate worse prognosis, but we're going to have it down in the table. And this is what we find here. For example, this is the same. This is a muscle. I had another one. Here, yes. So here you can see that this is a healthy muscle. So you have the nuclei here. These are the nucleus, and then we have here that there is dying of this or reduced sarcomeros of this muscle. And here also this is the dystrophin as well. Less dystrophin in these patients. And we have it here. So here is like normal dystrophin here, and then here are less common, and then the sarcomeres are starting to get deorganized. Weakness of the facial and distal limb muscles usually arise in young adulthood. Tired appearance, weakness and atrophy of the dorsiflexors of the feet produce step gait, and difficult to relax the muscles after contraction. And this is the table. I mean, we have. Yeah, actually, this is not even worth it that you have the second one. That if you only have this one, it's enough. So as I was telling to Pamela, so this one is not really that important that you know. It's important for you to know that they are linked to the X chromosome. Here, Duchenne is dystrophin absent. Becker is dystrophin abnormal. In this case, in the Emery, and this one we didn't see it. Did we see it? No. And then here, for example, it affects also the dystrophin. Rapidly progressive and die by age 25, 4th or 5th decade, and then we have normal life expectancy. And then the treatment, there is no cure for muscular dystrophy, but treatment might help to slow muscle weakness and manage symptoms. Depending of which muscular dystrophy we're talking about, we're gonna use corticosteroids, gene therapy, hair medications, because it also affects the heart, breathing support, braces and mobility aids, and surgery for a pacemaker or something like this. So all of this is just to get by the symptoms, but there is one way that in the syllabus is marked that you should know, although there is not, I mean, it's still not applicable in humans yet, but it is showing a lot of promises, and that is to use the CRISPR-Cas9 edition or gene therapy, right? So here we have this is like a normal gene, for example. I think it was for Duchenne's. And then we have gene 49, 50, 51, 52, and 53. The mRNA, it goes as it's supposed to go. And then we have a Duchenne patient. Here we are actually missing one gene, that is the 50. So here we don't have dystrophin since the protein cannot be synthesized. So what we can do basically is to with CRISPR-Cas9 to modify this part, and then this gene, and when this gene is actually read, then we can reframing and write what is needed. So then we might have a shortened functional dystrophin that could fix the problem, this genetic problem in these diseases. Questions? No? You sure?
I have a question.
Yes or no?
You said that they had a really bad prognosis. Yes. But I didn't understand if they can live, I mean, many years after their diagnosis, or
Yeah, I mean, Duchenne, it's gonna have the worst prognosis because it's actually advancing very fast. So we will have that at 5 years old, around 5 years old, 5 to 10, then they will start showing effects, and then they will lose the ability to walk, and then it would affect the muscles for breathing and the heart. So at the age of 25, kind of is the life expectancy. Then we have Becker, that it goes slower for some reason, and then it would also generate like it will cause death around the 4th or 50th decade. And then we have the other two. I don't remember the names. The fascious scapulohumeral type, that in this case the expectancy is normal. And then the myotonic dystrophy, that it will cause death at some point. It's not. It doesn't say actually in which decade of life it will happen. Maybe which months you have it here. We don't have it in this one. So this is the expectancy. I mean, but again, the most common one is this one. Okay. Yeah.
Okay, thank you.
Yeah. More questions? Is it clear, this part then? It's not difficult. I think I mean, here you just need to know what is dystrophin, that most of them are the X chromosomal genes, and that where is the effect, if it's actually absence of dystrophin or not. Then we have that for the myasthenic syndromes, we have just autoimmune diseases that affect different parts of the neuromuscular plate, and that's it. We don't have much more than that. And with that, we're finished, actually. Yep. Questions? Okay. Yep. So yeah, I don't know. I mean, I think that's it from my side. Then there is nothing else. There is nothing else. We cover, so I can actually show you again. We did it. I thought it would be a bit worse. So this is all the things that we have covered, is where all the exam comes from. This, you have all of this in the actually, I'm thinking, yeah, you have all of this in the syllabus. So if you can actually go through all of these objectives and answer, like just like as for studying for next Thursday, you can okay. So we can do this. For you to study, what I think is good is that you explain all of it, like you write everything here, and then on Thursday we go through the questions that you have, okay? And then that you will have like a good like basis for me to answer questions. Is that you are not like without a guide or something. This is your guide. It's very useful, I think, and I want you to, since I think, okay, I'm going to stop recording because I know.